Chapter 28, The Child with Cerebral Dysfunction, and this begins with increased intracranial pressure. Inside the child's skull, you have about 80% brain matter, 10% CSF, and 10% blood. Now, an infant whose sutures have not fused yet of the plates of the skull, there is a small window for compensation. They can spread out a little bit before you start getting increased intracranial pressure, but very little. It's a small window there. And otherwise, any increase in volume is going to result in increased intracranial pressure. And in fact, if you increase one of those, if you have cerebral edema, so you increase the brain mass, you're going to decrease something else, probably the blood flow. So you'd have a decreased amount of blood in the brain. If you increase one, you will decrease another of those three. Now, what causes increased intracranial pressure in kids? Anything that takes up space, like tumors, an increase in the fluid inside the ventricular system of the brain, that's where our CSF is formed, bleeding inside the brain, and cerebral edema. So just fluid inside the brain. And how do kids get increased intracranial pressure? Usually it's from a fall. So what are we going to see? What's the clinical manifestations of increased ICP? Well, in an infant, we're going to see tense and bulging fontanelles. We're going to see those sutures separated if they haven't fused yet. Well, we're talking about infants, so probably they haven't. There's a thing called McGowan's sign, and this is if you percuss on the skull, you get a cracked pot sound. I would not do this if you think this child might have increased intracranial pressure. You're going to see irritability and a high-pitched cry, and that's what parents will usually describe when they bring a kid in. They'll say, nothing I am doing is consoling him, and he never cries like this. It's high-pitched. It's not his normal cry. We're going to see increased head circumference, distended scalp veins, a change in feeding, and probably not feeding well, crying when disturbed, and setting sun sign, and that's what this picture is, the downward deviation of the eyes, and that's from pressure on the cranial nerves. And how about children? What signs are we going to see in children? Well, headache, nausea, vomiting, diplopia, which is double vision or blurred vision, so changes to their vision, and we may very well see seizures. We're going to get some personality changes on kids as well. They're going to be irritable and restless, or just sort of an indifference with their drowsy. If it's not a severe fall, it may not get caught right away, and in school you're going to see decreased performance. They're tired, they're non-attentive, they can't quite stay on task. So the school's going to say, decreased performance. You're going to see decreased physical activity, decreased motor performance. And I've heard parents say that they're sort of wobbly. They just were laying on the couch, and when they get up to walk, they seem kind of wobbly and bumped into the doorway. Increased sleeping and sleepiness, memory loss, inability to follow simple commands, lethargy and drowsiness. Now these are late signs. Hopefully it gets caught before these, but if not, bradycardia, decreased level of consciousness, decreased motor response to commands, decreased sensory response to painful stimuli. So you pinch their finger down, you get little or no, or some sort of abnormal response. Changes in pupil size and reactivity. That one always makes me laugh because it's such a late sign, but we check it pretty early. Decerebrate and decorticate posturing. This is abnormal extension or abnormal flexion. Kind-Stokes respirations, papilledema, and I have a sign of that, which is a very reliable sign of increased intracranial pressure in older children. but it is one of our late signs. And then coma. Now, something to note, that when you assess a change in the level of consciousness, that is one of the earliest indicators of improvement or deterioration of neurologic status. So we need to be very good in our assessment of level of consciousness. And most of the hospitals use the Glascow coma scale for that level of consciousness. It can range between 3 and 15, 3 being a very deep coma, 15 being totally alert and oriented and normal, what most of us are, hopefully, right now. 8 is considered a coma state, and the Glasgow is very good at separating in those lower stages between 3 and 8 how deep of a coma someone's in. Where it doesn't necessarily work great is in your elderly, occasionally confused, but pretty functional sort of person. That's where it can be a little hard to use. There is a difference you'll see there at less than 2 years old for verbal response, because those kids aren't really talking. Now, vital signs. What are we assessing in our vital signs, or what are we looking for when we are suspecting increased intracranial pressure? Temperature can sometimes be elevated and extremely elevated. We can have swelling pressure on that set point, and we can have our temperatures of 105, 106 that don't respond to antipyretics. So we're having to do cooling measures and cool the hyperthermia blanket, which is a cold blanket under the child. Pulse can really do just about anything. It can be rapid, or it can be slow and bounding. It can be feeble and weak. And usually if it's decreased, that's because of pressure on the vagus nerve, where it passes through the lower brainstem. Now, blood pressure can be normal, it can be elevated, or it can be decreased if the child's in shock. A decreased blood pressure on a kid is a very late sign. They don't have a decreased blood pressure until they actually are hypovolemic. They're in shock already. It can be up with a wide pulse pressure. That means the systolic's up and the diastolic's low. The difference between the two is wider than normal. That's your wide pulse pressure. And the child's doing that, it's a compensation. They're attempting to bring more blood and oxygen to the injured tissues. Respirations, again, we can get altered patterns. They can be slow, deep, and irregular. And that's from pressures on that respiratory center in the medulla. Now, just another note, in children, changes in the pulse and the blood pressure are more important than the direction of the change. So if we're seeing a change, that is significant, not which direction it's changing in. Okay, looking at pupils. Pinpoint pupils often happen with poisoning, especially if it's an opiate or a barbiturate. They can also happen with brainstem dysfunction. Wide and dilated pupils, we can see this after a seizure or trauma to the eye, and often that will be unilateral in that case. But it can also happen from pressure from herniation of the brain through the tentorium. So the brainstem has herniated down through that opening at the base of the skull. This pinches off blood supply to the rest of the brain. This is what leads to brain death. If the eyes dilate and are fixed for more than 5 minutes, usually this means we have brainstem damage, permanent damage going on here. Now, if it's unilateral, the dilation, usually this is from a lesion of some sort, and it's on the same side as the eye we're seeing dilated. Other things that can cause fixed pupils, well, brainstem damage, hypothermia, anoxia and ischemia, poisoning with atropine-like substances, and then if you put in eye drops that dilate the eyes. So, a nursing alert. If you see it suddenly appears, it hasn't been there, and now we see asymmetric pupils or dilated non-reactive pupils. This is a neurosurgical emergency. A child who has been comatose, but their pupils have been reactive and now they're not. Something has happened in there that probably needs surgical evacuation. Okay, doll's eyes. These are some of the tests we're doing when children are in a pretty deep coma, and we're trying to see just the extent of the brain damage that's been done. Looking for the doll's eyes test, you turn the head from one side to another side fairly quickly. Normal brain function, the eyes will stay focused on a point kind of straight out in front of the body, and as the head turns, the eyes go the opposite way so that they're staying focused on that point out in front. And you turn the head the other way and the eyes still stay pointing straight out midline, looking out, which would mean that they're going towards the opposite direction from the way the head turned. Now, that's normal. That's positive doll's eyes. A negative doll's eyes mean the eyes just, the pupils stay in the center of the eye and they move right along with the eye as the head turns. That's not, there's no attempt of focus or anyway, that's a poor sign. Now, obviously, if there's any concern about a C-spine injury, we can't be turning the head side to side. So if there's any concern of a fracture in the C-spine, we don't do the doll's eye maneuver. The caloric test. This is one of the things they use when they're evaluating for to see if a child is brain dead, to diagnose them brain dead. What's done is you irrigate the external auditory canal with ice water. This is supposed to be one of the most painful procedures you can do to a human being. Normally, if there's any brain function, you'll see the eyes move, and they move towards the side where the water was injected. Abnormal is to not respond to this, and that's an indication that the pontine centers are not working. Now, do realize this is incredibly painful. You would never do this on somebody who is alert. This is somebody who's in a coma, and we're trying to decide if there is any cerebral function left. Looking at the retina of the eye for papal edema is actually quite a good sign. This is swelling all along here. It's swollen. You can't tell great from this picture, but when you look with an otoscope, or actually an ophthalmoscope, into the eye, it would look more like swelling than there. It just looks a little fuzzy. This is not seen in infants, but in older children and also adults, and it's a very good sign of increased intracranial pressure, but it takes 24 to 48 hours before you would see this. If you look in there, you're also going to be looking for, is there blood inside the eye between the retina and the pupil, and that usually is a sign of that there's been some acute trauma, and there's probably intracranial bleeding as well.